Hello, everybody. Welcome to the Adult Advanced Life Support ERC Guidelines 2021 session. My name is Jaz Saur. I chair the Adult ALS writing group for the guidelines, and it gives me great pleasure to introduce my co-chair, Maria. Welcome, Maria.
Hello, good evening, everybody. I'm really happy to welcome you in this ALS Guidelines session and introduce the speakers. First, Mrs. Teresa Jahr from Karolinska University of Sweden, Dr. Charles Diggin from Southampton University, Jerry Nolan, of course, from Bath, Dr. Pierre Carlif, EMS Chair of Université de Paris, and Gavin Perkins, Director of Science Director of Guidelines at Vailcore, and that's all, I guess. Yeah.
Thank you, Maria. Weren't you going to introduce yourself?
Of course, my name is Maria, and I'm an anesthesiology trainee in Cyprus and the secretary of the Young ERC.
Great.
Welcome, and I hope you enjoy the session.
Thank you. So you can all start asking questions on the Congress platform. I'm just going to kick off quickly just by giving you an overview of the ALS guidelines. So you should just start to be able to start seeing my slides. So I'm just going to quickly show you the algorithm. And before I start that, I want to thank the writing group. And these are the co-authors on the group. We've only got a smaller group here presenting the guidelines. And these are the conflicts of interest. Mine in particular, I'm an editor of the journal Resuscitation, and I've received funding from the College of Anaesthetists to study perioperative cardiac arrest. This is the 2021 ALS algorithm. It's largely unchanged from the previous 2015 version. And high quality chest compressions are still emphasized, and identifying and treating reversible causes. We still have the 4 H's and 4 T's. There's a slight emphasis now on ultrasound to help identify some of these. And again, considering coronary angiography, mechanical CPR, ECPR. And these are the top 5 key messages. So high quality chest compression with minimal interruption, early defibrillation and treatment of reversible causes. In patients who haven't arrested, the importance of premonitory signs and symptoms that, if they're recognized, can be used to help prevent cardiac arrest. The use of basic and advanced airway techniques, and limiting tracheal intubation only to those settings or rescuers with very high success rates, use of adrenaline, and in select patients, the use of ECPR. Now, what I'm going to do, I'm going to stop there and introduce our first speaker, Dr. Teresa Jahr from Sweden, and she's going to cover some of those key points in terms of prevention of cardiac arrest. Thank you.
Yeah, thanks, Jess. And thank you also ERC for the opportunity to talk about in-hospital cardiac arrest. So what is most important, of course, this is my conflicts of interest. Slide like that. Yeah. So in hospital, we need to understand the key concepts. And there are 5 keywords. There are monitoring, recognition, call for help, and the response, and education. And that is mainly vital signs and how to act upon them, and also how to go from BLS to ALS, identify reversible causes and treat them. So, simple as that, yes it is. However, the problem. So, this is what's been going on for a very long time. We knew since at least 20 years back that most of the in-hospital cardiac arrests are avoidable. And I really hope that we won't come back in 20 years and say the same thing. So we need to do something else. And what I would like us to do is really to break the chain of survival, or break the mental picture of it. it's not going from left to right. It's not a linear thing with a start and stop. Instead, I think it should be circular. This is the reason behind it, because these links are working very well in hospital. And if you try to, instead of doing a circular chain of survival, you see the tip of the iceberg. That works very well. But below the surface, we need to do something better. We need to review cardiac arrests in a data-driven way. And we know that if we do that, we might reduce incidence, we might increase survival, and that's good. So, and then we need to use this as feedback to those who actually perform the CPR and to the wards who had the patients. And we use that information to actually teach and simulate in situ real cases. And also, I think it would be informative to know for a hospital who actually get a cardiac arrest in this hospital and what is the outcome. And that will be helpful when discussing DNRs in a simple hospital. And then go up again, should we monitor these patients if you're not going to do CPR? And then we're back again on tip of the iceberg and running down. So you see the Rubik's Cube in the middle. I think we actually have to be curious about this. And we have to twist it around, and we have to educate on every single link in this chain to reduce the incidence, because I think we have too many cardiac arrests in hospitals. It's patients, and they have educated personnel around them. So that's the main difference between hospital and in pre-hospital settings. So education. And I think I've stopped there, actually.
Thank you, Teresa. The sound wasn't great on your thing there, but I've not seen any questions on your talk so far. So Maria, do you want to introduce the next speaker?
Sure. Next speaker is Charles Diggin on defibrillation.
Hi, Charles. Do you want to come onto the screen? You just need to unmute yourself.
Can you all see that? Yeah.
Yes.
Sorry. Okay. So I'm just going to talk very quickly just about defibrillation, and just to update you on one or two key aspects of defibrillation. In terms of conflicts, I've got a few research grants and trials, but nothing directly conflicting me in terms of defibrillation. So Shockal rhythms, of course, are a key component of ALS, and although they generally make up no more than 20% of the initial rhythm, by far the majority of survivors come from patients with shockable rhythms. So the optimal management of patients in shockable rhythms is really key in terms of optimizing overall survival from cardiac arrest. And you can see at the bottom there, by far the vast majority of patients who survive have been in a shockable rhythm, certainly compared with non-shockable rhythms. You'll all be aware that defibrillation is time critical, and the chances of successful defibrillation decrease about 10% for every minute's delay. Most ambulance services struggle to do anything better than 8-minute response times. One or two areas in the world manage about 4 minutes, where they certainly have better outcomes. But because of the inevitable ambulance response times, there's been a lot of emphasis on bystander defibrillation as a sort of add-on to the chest compression side of things. And you can see there that by adding defibrillation to patients with shockable rhythms, survival rates of about 50% have been achieved. So there's a lot of emphasis at the moment in terms of improving bystander AED response, recognizing that that's actually potentially going to save a lot more lives than the ambulance response because of that inevitable delay. You've already seen the a summary of the actual ALS algorithm, and I just wanted to talk very quickly about three key things. First of all, the shock energy levels, and we're still recommending essentially that the initial biphasic shock energy should be at least 150 joules for all waveforms on the shockable side of the algorithm. In terms of 1 versus 3 shocks, again, nothing's changed with that. We're still recommending a single shock on this arm of the algorithm, unless you're in a situation where it's a witnessed and monitored cardiac arrest, such as in a cath lab, where it's acceptable to give 3 quick shocks, which cumulatively counts as the first shock. And finally, fixed versus escalating energy levels. There's really no further evidence since the last guidelines in 2015 as to the optimal protocol, whether it should be fixed or escalating. There's a little bit of evidence suggesting that escalating may be better if the first shock hasn't succeeded. So the recommendations remain that if a defibrillator is capable of delivering shocks of higher energy, then it's reasonable to give subsequent shocks at higher energy levels than the initial shock. I just quickly wanted to mention about refractory VF. There's been quite a bit in the literature about that over the last few years. Refractory VF is generally when patients still remain in a shockable rhythm after 3 shocks. And I just show this schematic showing that when pads are optimally placed, obviously the aim is to sandwich the heart between the defibrillation pads. I think one of the problems with refractory VF is probably that the pads aren't always placed in the right place. And although it's a bit of a schematic, hopefully I can demonstrate that if particularly the apical pad is placed too medially, then actually it results in a lot less of the myocardium receiving that shock, which may end up in these refractory VF situations. There are, of course, other causes, but I just wanted to emphasize the importance for shockable rhythms of pad placement. And this is a diagram that appears in the revised guidelines, just really to emphasize where to put the apical pad. So essentially, it should really sit under the armpit in the mid-axillary line. So it's right round the side, so that this position generally sandwiches the heart, as I showed in the first diagram. Lots of defib pads end up being placed much too medially or even down on the abdomen, so which we don't want. So really important in terms of that pad position. I just wanted to mention quickly dual sequential defibrillation. Again, there's been quite a lot in the literature about this over the last few years. So dual sequential defibrillation involves essentially using 2 defibrillators and 2 pairs of pads with the aim of firing both defibrillators at about the same time to deliver twice the energy for patients in refractory VF. So generally, the first pair of pads are anteroapical, as shown here, and then in most cases, the second pair of pads tends to be anterior-posterior. So you end up with 2 vectors of defibrillation current, one from front to back and one from side to side. So we've reviewed that for ILCOR in terms of the effectiveness, and this forest plot I think shows you. You can see on the right here, this favors dual sequential defibrillation. On the left, this favors no dual sequential defibrillation. There's certainly no signal here that dual sequential defibrillation improves outcome. And in fact, there is some suggestion that it may actually be harmful. There's no doubt that too much energy is harmful. This is some dose response curves for defibrillation, and you can see that obviously if you give too little energy, you don't successfully cardiovert as the energy levels go up, and so does the success rate. But once you reach this plateau, all you achieve by increasing energy levels is increasing myocardial damage and ultimately death. So with the current recommended single defibrillation, we're somewhere here, and with dual sequential, we're probably not actually achieving much more in terms of defibrillation success, but certainly risk damaging the myocardium, and shocking someone out of VF into asystole is not a success. So that may explain some of the reasons why we failed to see any improvements in dual sequential defibrillation. So in summary, the essential defibrillation guidelines have not changed from 2015. Just to remind you all, it's obviously a time-critical procedure, and it's really the group of patients where we can make a big difference to their outcome if defibrillation is done promptly and effectively. The aim is to terminate VF to restore a perfusing rhythm. We certainly don't want to overdo it with too much electricity to cause asystole. 150 joules for initial shocks, and then consider escalating for refractory VF, obviously if you've got a manual defibrillator. That pad position, very important in terms of getting that apical pad under the side, underneath the armpit. And finally, dual sequential defibrillation is of unproven benefit. Thank you.
Thank you, Charles. You can stop sharing there. So lots of questions on defibrillation. Maria, do you want to pick out a question?
As I see here, there are 2 questions regarding the chest compression coach.
No, to do with defibrillation.
For defibrillation.
For Charles.
Yes, one question is regarding does the plateau of defib effectiveness conflict with the escalating shocks?
No, so that window I showed for the single shock was basically covered the range of what we recommend. It was a logarithmic scale along the bottom. So that covers the range from 150 up to 360 joules. If you have the opportunity to go back and watch it on YouTube, you'll be able to freeze the image and actually see these scales. But no, that was not an issue in terms of what we recommend at the moment.
Charles, there's some questions asking about fine VF, asystole, compressions or shocking. Do you want to clarify that issue?
Yeah, I can't see the questions, Jazz. So, but in terms of fine VF, essentially, if you look at the monitor and there is anything that resembles VF, fine or otherwise, then it's important to get on and shock the patient. Not shocking them is not going to really get them out of VF. So it's very important that if you suspect it's VF, that you deliver a shock. And I think we've emphasised that in the guidelines this year. Sorry, Jazz, has that answered the questions? I can't see them all.
Yeah, and it's just that I'm just paraphrasing 2 or 3 questions there. There's another question about shock strategy. So we've recommended, a pause to look at the monitor, charging, shock, and charging for every shock. Or is there any particular way that's better than another for manual defib?
Do you mean in terms of charging prior to ending the 2-minute sequence? So I know some parts of the world, such as Australia, pre-charge before they get to the end of the 2-minute sequence. There are some pros and cons with that. There are no studies showing that actually improves outcome, and there's some studies showing that it may actually reduce the speed and efficiency of defibrillation for various reasons. So we've stuck as we've recommended in the past with the current guidelines in terms of charging at the end of each 2-minute cycle.
Maria, any other questions on the feed to do with defibrillation? I was going to ask one more question.
Yes, sure.
When we show double sequence defibrillation, do you think it could be that just changing the pad position is the benefit as opposed to giving 2 shocks? So, if you have refractory VF, is it worth changing the pad position?
It's certainly worth considering. I think the first thing, though, with refractory VF is to make sure that your initial set of pads are in the correct place. So if there's no evidence and there have been no studies looking at whether one pad position is better than the other for VF, it wouldn't be unreasonable, if you're happy that your initial pads are in the correct place and they're ineffective, to consider changing front to back. But there is no evidence that's any better than the anterolateral position that we recommend as the default.
Other questions on defibrillation?
I think he just answered one of the questions I was going to mention about the pads position, about apical and vertical or horizontal, if there is any difference.
Oh, the actual pads themselves, yes. So the pads that are rectangular, Essentially, for biphasic defibrillation, it makes no difference whether you put the pads on sort of that way round or that way round. It did with the old monophasic defibrillators, but biphasic defibrillators measure the impedance and then adjust the output accordingly. So there is a little bit of difference in the impedance between the orientation of the pads, but I think it's fair to say that with biphasic defibs that measure the impedance and then adjust the current that it delivers, it's not a problem. So you can put them on either way.
Great, thank you. I think we're going to move on because we've still got 3 more sections. So just remembering, I think it's Jerry Nolan talking about Airways next.
Yeah, I think it is, Jazz. I'm going to share my screen. Hopefully you can see that reasonably clearly, I hope.
Yep, that's good, Jerry.
Excellent. Okay, so I'm just going to spend a few minutes just discussing airway and ventilation. Obviously, I'm not going to cover everything that's in the guidelines, but I'm going to give you a little bit of background to some of the science behind it, and then really a summary of the points. And I guess I should point out that this sort of title slide kind of summarizes it really, because this is showing in picture form the stepwise approach to airway management, and I think that's probably the key. Here are my conflicts of interest. I guess the main one for this is that I was a co-investigator for the Airways 2 trial, which I'll mention very briefly. So in terms of science for out-of-hospital cardiac arrest, as you probably recall, we've got 3 randomized controlled trials now, all published in JAMA in 2018. This was the first of them. The CAM trial was done in France and Belgium, pre-hospital physicians, and they basically randomized out-of-hospital cardiac arrests to either have bag mask ventilation with intubation delayed until after ROSC, compared with early intubation. And you can see about 1,000 patients in each group. And the bottom line, if you look at their primary outcome at the end of the slide there, 28-day neurologically favorable outcome, no difference between the two in essence. Key to this study, though, is that the intubation success rate amongst those pre-hospital physicians was 98%, which is one of the highest, I think, documented in an RCT. The second study I just want to mention, this is the PART trial from the United States. It compared the laryngeal tube with initial tracheal intubation, as you can see here, about 1,500 patients in each group. Their primary outcome was 72-hour survival, simply because they didn't have the funding to look at the longer-term outcomes. And interestingly, in this study, they showed a favorable difference in favor of the laryngeal tube, 18 versus 15%. But really key, I think, is if you look at the bottom of the slide down here, the intubation success rate overall was just about 50%. So one might argue that this was a study that showed that if you don't have a high success rate with tracheal intubation, you're probably not going to do as well. And then finally, this was the Airways 2 trial. It was done in the UK. It compared the iGel, a strategy, should I say it first, using the iGel versus tracheal intubation. And you can see the primary outcome here is modified Rankin score of 3 or less, so neurologically favorable outcome, and no significant difference between those two, as you can see. And the intubation success rate in this study, interestingly, was somewhere between the two at around about 70%. So you can see that with very large randomized controlled trials, we've still failed really to show a significant difference with one form of airway technique over another. What about in-hospital cardiac arrest? I'm really just going to show one study. This is probably the best one, I think, still done. It was an analysis of the US Get With The Guidelines Resuscitation Registry. And essentially, it was an observational study that was looking at patients in the first 15 minutes of in-hospital cardiac arrest in the US. And they basically compared patients that were intubated, looked at every minute within that first 15 minutes, and compared those that were actually intubated, and then sort of linked them with patients that were similar in all other respects, except they weren't intubated in that minute. So this was really a technique of using propensity analysis, as you can see. And the bottom line, if you look at the propensity matched groups, and you can see large numbers of patients in this trial, I've highlighted in red, survival to hospital discharge. This is the no intubation group on this side, and you can see it's about 19.4% survival compared with 16.3% in those that were intubated. So this observational study suggests that, and remember this is really just an association, that you're actually worse off with early intubation after in-hospital cardiac arrest. But I must emphasize this is not a randomized controlled trial, and there still could be confounders in there that have not been accounted for in the statistics. So where are we in terms of the sort of summary points in the current ERC guidelines for airway management? Well, I've already mentioned the first one, which is a stepwise approach, as you can see there. We have suggested strongly that you only attempt tracheal intubation if you've got success rates of something like 95% or more within 2 attempts. So that's a pretty high bar to set, but I think that is on the basis of some of the studies we've seen. Minimal interruptions to chest compressions, and we're suggesting that it should be 5 seconds or less. And then direct or video laryngoscopy according to local protocols. And many of you will feel strongly that video may be better than direct and vice versa, but we don't have any strong evidence one way or the other. We do suggest very strongly, firm recommendation that we should be using waveform capnography to confirm placement of the tracheal tube. And finally, my last slide, just a few more other points. During CPR, we're still recommending that you give the maximum inspired oxygen concentration. Obviously 100% if you can give it, but there are many systems that won't allow that. You can then use, if you're using a bag mask, we still recommend using the 30:2 compression ventilation ratio. In other words, pausing the compressions to deliver the 2 breaths. And then finally, once an advanced airway is in place, then we're still recommending to then deliver 10 breaths per minute whilst continuing chest compressions uninterrupted. And I'm going to stop there and be very happy to take any questions.
All right, thank you. Maria, any questions for Jerry on airway?
One question, if Jerry thinks that we should wait until ROSC to intubate, what is his opinion about that?
Yeah,
and
I think it's a very good point, Maria, and we've discussed this at length as to whether we should specifically say that. In some respects, the stepwise approach addresses that, because the whole point is if you're successful with your basic airway management and you're effectively ventilating that patient, then I think it is very reasonable to wait until ROSC to intubate the patient. However, if the technique's not working and you have the appropriate skills, then you would go up that ladder and advance the airway. So I think the reality is, yes, in many cases, I think certainly advanced airway management will be potentially delayed until after ROSC, but that's not a blanket rule. It depends on the circumstances and the skill of the operators.
Okay, there's a few questions there. What about in COVID? Are we pushing towards more intubation and use of filters, or?
Yeah, I obviously specifically didn't mention COVID, and we've got separate COVID guidelines talking about that. I think the key thing is that if you're going to be doing any airway intervention with a patient that has either got COVID or may well have COVID, then obviously you shouldn't be dealing with the airway until you have proper airborne precaution PPE on. And yes, if you've got the appropriate PPE, and you've got people who are highly skilled in tracheal intubation, there is a lot of sense in intubating relatively early, because once the tracheal tube is in the right place and the cuff is up, the airway is sealed then, and then with the addition of a filter, then that should minimize the risk of both generating and indeed disseminating aerosol containing COVID.
Any other questions, Maria?
Sure. If there is any difference in the ventilation strategy if we're using a mechanical chest compression?
Yeah, that's a good question, which we haven't looked a lot into. And as somebody who personally doesn't have a lot of experience with mechanical ventilation, it's difficult for me to comment. But what I would say, I think, is the chances are, if you're using a supraglottic airway, I suspect that using a mechanical device, you're going to get quite a lot of leakage. And I think it's going to be a question of trying to deliver those ventilations sort of between compressions. I think using mechanical devices, I suspect you're better off if you've got the skills of having a tracheal tube in place. Well,
one of the things that's coming up is, in what circumstances do you go to continuous compressions as opposed to 30:2? So mechanical devices with a supraglottic airway? What about bag mask valve and just standard compressions and so on? Because there is quite a lot of controversy about this, isn't there?
Yeah, you're right, Jazz. I mean, one of my bullet points did say that we're still advocating that you actually pause the chest compressions. If you're using a bag mask alone, you do pause the chest compressions and then deliver 2 breaths and keep with that 30-to-2 ratio. There are people certainly there are systems in parts of the world where they don't do that, where they actually continue to do chest compressions and deliver the breaths asynchronously with a bag mask. I don't think we've got strong evidence one way or the other. The reason that we advocate not having a pause is that I think there's still concern about the potential for a higher risk of gastric inflation with air if using a bag mask device and continuing with compressions at the same time. But I don't have good evidence for that, I have to admit.
Okay, I was just going to ask you one more question, Jerry. Do you think it's easier to teach people to put in a iGel or a supraglottic airway than bag mask ventilation?
My personal view is very clearly yes, it is, and I know that's your view as well, Chaz. Unfortunately, we don't have really good evidence for that, but I think that is probably true. And some of us may have heard both of us speak in the past where we've actually flipped that sort of stepwise approach and actually put the iGel sort of lower down the stepwise approach, i.e. suggesting it's easier and more effective to do that than it is bag mask ventilation. And I know the comments from, Pierre and his colleagues were involved with the CAM trial, and the comments from them was actually, if you're skilled at intubation, it's actually easier to ventilate, stick a tube in and ventilate somebody than it is trying to do it with a bag mask device. And I think that's a very important observation coming from highly skilled people.
Okay, thank you. Maria, do you want to introduce the next speaker?
Sure. Next speaker is Gavin Perkins, who is going to talk about drugs during CPR.
Great, thanks very much. If you could pop my slides up, please.
So, Francesc, can we put up Gavin's slides, please? So we're just waiting for Gavin's slides to come up. So here they come.
Great. I mean, while we're waiting for the slides to come up, I'm happy to start. Jazz. Great. So we're on the first slide. So I'm Gavin Perkins and pleased to provide an update for you on drugs and fluids. If we could move to the next slide. My conflicts of interest are academic related, having been the principal investigator for the Paramedic 2 trial and also having roles within the International Liaison Committee on Resuscitation and the European Resuscitation Council. Next slide, please. I'm going to be walking you through these 5 key topics relating to drugs and fluids: vascular access, the use of vasopressors, antiarrhythmic drugs, thrombolytic drugs, and fluids. So moving on to the first of those, vascular access. The ERC guidelines are permissive of the use of both the intravenous and the intraosseous route for drug administration. If we could move to the next slide, please. And the context for that permissiveness is really uncertainty about which of these approaches is the safest and most effective. And I think this is summarized really quite eloquently in this recent review published in the Scandinavian Journal of Trauma and Emergency Medicine, which has highlighted heterogeneity and uncertainty about the most effective route of drug administration, and noting really, as we have done in other studies, one of the challenges of comparative studies, or at least observational studies, is the issue of resuscitation time bias. And if one of the interventions is used as a reserve intervention in the event of a primary access route failing, that often confounds and leads to the introduction of bias, making it really quite difficult to know which is the safest and most effective route. And we certainly, or I certainly agree with the call here for further research on this topic. And indeed, it's something we're hoping to do over the course of coming months in the UK. So moving to the next slide in relation to the use of vasopressors in cardiac arrest. This was summarised in both the ILCOR systematic review, but also the Cochrane review led by Judith Finn, which showed that adrenaline is effective at achieving return of spontaneous circulation, survival to hospital admission, and also has an effect through to survival to hospital discharge, although the meta-analysis of the Paramedic 2 study and the PACA trial from Australia not demonstrating evidence of improved neurological outcomes. The guidelines recommend that adrenaline is given as soon as possible in non-shockable rhythms because the greatest chance of success is if you intervene early in cardiac arrest. For shockable rhythms, the recommendation is that the drug is delayed until after the third shock, and that the frequency for repeating drug is in cycles of 3 to 5 minutes. Moving to the next slide, please. No change in the position of the use of antiarrhythmic drugs. We continue to recommend amiodarone after the third shock has been unsuccessful, so in shock refractory ventricular fibrillation or pulseless ventricular tachycardia, and we permit lidocaine as an alternative where that's not readily available. And just as a reminder, this is based on the work from Pede and Kudenchuk's study, which showed in their a priori subgroup analysis that people with bystander witnessed cardiac arrest who received the intervention received benefit compared to placebo with both the amiodarone and lidocaine treatment. Moving to the next slide. Thrombolytic drugs, no new science really in relation to the use of thrombolytic drugs, so the treatment recommendation remains the same. Not for the routine blind use, but if there's a strong suspicion of pulmonary embolus, one can consider the use of thrombolytic drugs. And on the basis of case reports that are referred to in the guideline that have shown return of spontaneous circulation and favourable outcomes after a time period of 60 to 9 minutes, it's suggested that one considers continuing advanced life support, depending on the overall context and progression of the patient's response to treatment. My final slide brings us to the use of intravenous fluids. And on the basis of the studies that have used the use of cold intravenous fluids, so indirect evidence that have shown giving large volumes of cold intravenous fluids can have an adverse impact on ROSC, increase the risk of rearrest and pulmonary edema, that we suggest that the routine use of large boluses of intravenous fluids are avoided unless there's clearly evidence of hypovolemia. That wraps up the part of the presentation, and I'm very happy to take questions.
Thank you, Gavin. Just looking at the questions. Maria, is any questions that stand out?
Just one that popped up now, considering the effect of adrenaline on the neurological outcome after a prolonged cardiac arrest.
Yeah, so I think, and it's a point that the Advanced Life Support Task Force of ILCOR made, and Jazz, as the chair of that task force, may also wish to comment that the effect of adrenaline continue to be effective insofar as restarting the heart. Beyond the window with which cerebral resuscitation is possible. And we published a study in intensive care medicine about 12 months ago that I think illustrated the point effectively or nicely, that if you give late adrenaline, it can restart the heart, but it's probably at the point by which the brain is too late to be resuscitated. But Jazz may have further insights on the task force's discussions on that matter, because I know it was a point of discussion.
Yeah. Yes, thank you. So in my role as the ILCOR ALS chair, the considerations were early adrenaline probably helps restart the heart. And the signal from harm from adrenaline probably comes from the fact that it restarts the heart at a stage in some patients when their brain is already damaged. And the question is, do you stop giving adrenaline? We don't know where the cutoff is. And the data suggests that adrenaline increases the number of good survivors, but also increases the number of poor survivors. And so if you got rid of adrenaline, there may be fewer survivors altogether. It's hard to say. But more importantly, it means we need better strategies at protecting the brain during CPR. We need better prognostication strategies. And one of the side effects of adrenaline, I think, is more organ donors. So it's not all bad news. And currently, the balance is still in favor of giving adrenaline during cardiac arrest, and especially if you give it early. I think the challenge is we don't know the best dose, the best timing, and the best way of giving it. And 1 milligram every 4 to 5 minutes may be the wrong way of giving it. We don't have a titrated way of giving it. So yeah, we're still using it. We just don't know the best way to use it.
So, and Jazz, if I could maybe just add one quick, comment to that, and and to really agree, and I guess it's a societal question in relation to organ donation, but certainly in our cost effectiveness analysis that was published earlier this year in Critical Care, if you include the societal benefits of organ donation, then the use of adrenaline becomes cost effective. So, again, an area, I think, of, ongoing debate and interest.
Thank you. Thank you, Gavin. Any other questions? I think we probably need to move on to our final speaker, and we can take on more questions at the end. So, Maria, did you want to move on?
Next on is Professor Pierre Calif talking about ECPR.
Thank you, Maria, for this very kind introduction. And indeed, it's the last point, but it's an important one. Ecmo Ecpr is part of the guidelines. I have no conflict of interest to declare, but if you look at the advanced life support algorithm, you will see that Ecmo have been incorporated to it. It's a small place at the time being. It's only considered, as you see, with the coronary angiography, the mechanical chest compression, and ECPR. Indeed, in Europe, the use of veno-arterial Ecmo Ecpr in cardiac arrest patients is increasing. But it's now universally agreed, and the data are lacking in most of the point to use efficiently Ecmo during CPR. However, if you consider the current literature that has based the guidelines this year, it was clearly obvious that we can only decide on something limited for the use of ECPR, a rescue therapy for selected patients when all other measures are failing. And it's also something important to facilitate specific intervention, but it has also to be implemented in settings where you have a whole system to manage ECPR with the rest of the chain of survival. Well, we'll quickly comment this, and clearly the new data that happened since 2019 are exactly in the same direction and makes this recommendation very accurate. The first point is rescue therapy. If you consider this registered, you see that the survival to hospital discharge in the patient receiving ECPR and conventional CPR is almost the same. But you have to notice that ECPR was done as a rescue. So it's a good rescue in terms of survival. Very recently, it has been published in the Lancet, the only RCT with ECPR, Dimitrios Yiannopoulos, on a small number of patients, show that survival was improved in the group receiving ECMO. More interestingly, in this small group, he observed an improvement of neurological outcome. So let's say that for a rescue therapy, ECMO is a very good one. And maybe in the future, in a few years, it will be more than a rescue therapy. The second point that is a very important one is how to select the patient. Common criteria, it's witness cardiac arrest. Time to establish CPR quick, less than 60 minutes. Young patient and know the possibility to have a treatable underlying cardiac cause of the cardiac arrest. I will insist on the fact that the selection is important. In this recently published paper, you observe that there is no survival when the patient is in asystole and when the patient has no sign on life. And in the other group, it's different. That means that in some patients, it will never work. And in others, even in patients in asystole, there is an opportunity that eCPR will improve prognosis. Considering the time to eCPR, it's known for several years now that we have a kind of golden hour. During the 60 minutes, you have to implement the eCPR. Then now I will conclude on this side, but I consider this to be the most important one. ECMO by itself will not save life alone. ECMO has to be involved, implement in a whole system that will save life. And in this paper, our US friend showed that it was possible to implement ECMO in the pre-hospital setting or on arrival in the hospital, and to build a system with, in this example, a rendezvous, a point of rendezvous in the nearest facility to implement ECMO, and then transport the patient to the specialized ECMO center and cardiac arrest center. To conclude, I will say that probably ECMO is the only chapter, paragraph of the guidelines where what has been published is, let's say, less long than the question that remain unresolved. And you see that the knowledge gap in ECMO are still very important. So there is room for a lot of work in all the cities that have already implemented ECMO network. Thank you for your attention.
Thank you, Pierre. Maria, any questions for Pierre?
Sure. One question is regarding the transportation of the patient to an ECMO center or ECMO at the field.
So,
what's your opinion?
Yes, thank you, Maria. It's a very important point. So the aim is the result. If you can implement quickly ECMO in 60 minutes, never mind the way you do it. Your system has to do it quick. So clearly in Paris, we've chosen to have a pre-hospital team and to do ECMO on scene. But when we have compared this strategy to the implementation in hospital, clearly the point was the time to ECMO and the selection of the patient. So it's really compliant with the guidelines that have been published now.
When does cardiac arrest become refractory? You know, when would you switch? You know, when is the sweet spot?
That's the best question. That's the best question, indeed. In fact, a prolonged cardiac arrest in VF and an effective ALS is important, but up to what time, to what minute? And clearly, if you implement the ECMO early, you'll have better results. But obviously, at the time being, we can only recommend that ECMO has to be implemented in this 60 minutes. At the time being, for example, in Paris, we have the ECMO team that will go to the scene in less than 15 minutes in order to implement ECMO at the 20th minute. So clearly, if we can do that early, we have to demonstrate before that ECMO by itself is as effective as the classical CPR, and we have to include the fact that ECMO is important in terms of cost, efficiency, and also that ECMO is not available everywhere.
Okay, any more ECMO questions? So what are the simple inclusion criteria? Yeah, clearly we didn't give any very hard ones, but if you're going to pick winners, what would you be picking? What patients?
We pick winners doing CPR. That's important. The sign of life is really important. And it's not the rhythm, it's clinical history, the fact that we have witness on scene, but if you see that the patient during CPR is awaking, opening eyes, gasping, all these signs are signs of possible good prognosis if you can replace his circulation by ECMO. And that's obvious. It means that the brain at that time has not been, let's say, damaged without any chance of survival. So to select the patient, we select the patient that in the field seems to awake, seems not to be dead during CPR. That's an important point in terms of prognosis.
Right. Any more ECMO questions?
Maybe one last one about is there any cutoff point when is the best time to move the patient to the hospital during ECMO?
If I understand what you mean is that ECMO has been implemented on scene,
yes,
and then you move the patient, you
yes,
are no more in a hurry. You are no more in a hurry. When the patient is under ECMO, the patient, in terms of, let's say, circulatory point of view and brain oxygenation point of view, it has its best. So clearly, you are no more in a hurry. The problem is when you transport the patient to ECMO centers, in that case, every minute counts, and clearly, that's more difficult. And as you know, prolonged resuscitation is not, at the time being, a very controlled protocol everywhere. So that's part of the reason why we have chosen to implement ECMO in the field when it is possible and when it's adapted to the time to the ECMO center. Okay?
Thank you. I was saying we've got 10 minutes left and we can just take questions for the whole panel. So Gavin, you can get your video back on and all the speakers can be back on. So I was just looking at, what are the top questions that we've not answered, and there's quite a lot. And if people have picked up questions on their topic, please do answer them. So one question coming in, Charles, I've seen is just clarifying the shock energies. So I think I'm right in saying that we recommend following the manufacturer's guidelines for their particular defib, but when that's not known, you've got to have an alternative.
Okay, so yes, it's my slide was quite simplistic. What the manufacturers recommend is not necessarily always starting at 150 joules. One or two manufacturers suggest that 120 joules might be adequate. There's no evidence for one or the other. We prefer 150 joules because there is some evidence that when you compare 120 to 150 joules, first shock success is better with 150 joules compared with 120 joules. So although the manufacturers may, for some devices, recommend 120, I think we would prefer that people were starting with 150 joules for that initial shock.
Great. And then if that doesn't work, what are your options?
So if that doesn't work, make sure that the pads are in the correct place, I would say. That would be your next option. But assuming they are, then you've obviously got the choice between fixed and escalating energy levels. Again, there's very little evidence to support one strategy over the other. There's some weak data suggesting that an escalating strategy may be more effective. And so we suggest that if you've got a manual defibrillator and you are able to increase the output, then to consider increasing energy levels. One thing I would just add is that there's quite a lot of confusion between defibs, some of which only go up to 200 joules and others go up as high as 360 joules. The difficulty in comparing all these devices is that the waveform, how the energy is delivered, is actually quite different in the devices. And without being specific about the actual manufacturers, some devices, for example, at 200 joules maximum output will deliver at least as much current as other devices at 360. And actually, it's the current that probably determines defibrillation success. So don't be lulled into thinking that just because your defib only goes out up to 200 joules maximum output, it's some way inferior to a device that only puts out 360. There's no evidence that those maximum energy levels are any better or worse than others. So if you've got a device that only goes up to 200 joules, it's likely to be just as effective as devices that go up to 360, because it's the current that defibrillates, not the actual energy that the devices are delivering.
Okay. Any other questions, Maria, that are trending? You need to unmute yourself.
Yes, one regarding mechanical ventilation and the CCSV mode that was mentioned in one of the symposia in the afternoon.
So this is for you, Jerry, using a mechanical ventilator during CPR, and anything to comment on that?
You mean in relation to the airway management and ventilation?
Yes.
I mean, it's not something we've actually put in the guidelines, and I've seen so little data on that. It's going to be difficult to comment on the basis of any science, but obviously, if you're using a mechanical device, I think it's going to be much more difficult to deliver ventilation with anything other than a tracheal tube, and unless you can pause it and deliver ventilations between compressions, because I think trying to do it at the same time is going to be very difficult. But I can't comment based on any science.
Any comments on any of these insufflation techniques or anything that, again, we don't recommend in the guidelines?
You mean sort of passive oxygenation?
Yes.
Yeah, again, we've got so few data on that. I think it's in theory, it's a potentially attractive technique. The idea that you just insufflate oxygen down, especially if you just do it down, say, a supraglottic airway or something like that, and then continue doing your compressions. But nobody's really ever studied that in any detail. So we just don't know how effective or not that is.
Okay. We're coming to the last 5 minutes. Is there any final top questions, Maria, that you want to ask anybody?
Maybe one for Gavin regarding, is there any cutoff of volume resuscitation during CPR? How much is too much?
You mean fluids?
Fluids, yes.
Yes, so I think the guidelines advocate that unless you think the person is hypovolemic, that we wouldn't routinely support the use of intravenous fluids. I guess if the person is hypovolemic, again, it's based on core principles as opposed to there being clear data of benefit one way or another.
Right. I was just going to start closing the session. I'm just going to go around the speakers. Any final messages? So Therese?
So my sound is bad on my internet, but I hope you hear me now. But I think that we should prevent what we can prevent by vital science and ethical decision. And that is the main key thing in hospital.
Okay. Charles?
Just make sure that apical pad is underneath the armpit, right round on the side.
Do you want to stand up and show us exactly where, Charles?
I'm not sure everyone wants to see my armpit, Jazz, but I don't know which way I am round on the screen. Am I the right way round?
Yeah, that way. Yes.
That way. So just about here, somewhere about here.
Excellent.
Right round to the side.
Good.
Okay, thank you.
Yes. Who was next? Jerry, Airways.
Yeah, well, I'm not going to do any demonstrations of Airways because that will put people off their dinner for starters. But yes, I must emphasize, of course, the stepwise approach and, matching, I think, the skills of the operator with the airway management strategy.
Right. And Gavin?
BLS is best. CPR and defibrillation, public access defibrillation make a much bigger difference than ALS.
But ALS adds value when needed. Is that right?
Yeah, no, I think that's fair, Jazz.
Okay, and Pierre?
Okay, my conclusion will be Ecmo has to be implemented in the best system. It's wonderful, but you have to be top in basic CPR, you have to be top in advanced life support, you have to be at the top on organization, and then Ecmo will be a plus. More life saved by Ecmo.
Okay, thank you. Maria, any final comments before we close?
I would like to thank everyone for their wonderful speaking, and good night. I hope you enjoy the rest of the Congress, to everyone.
Yes. So thank you to all our speakers. I've seen we've got hundreds of questions and we can't answer them all right now. Some of the answers are in the actual guideline paper. In 30 minutes, Jerry's going to be leading post-resuscitation care. And then after that, there'll be an evening hot topic session. So please do join us again. And thank you. Thank you to the audience and to all the speakers. Thank you all. Bye.
Thanks, everybody.